Thank you, chairpersons. At the outset, I would like to thank the CNCI and specifically Dr. Debashri Shannal for giving me this opportunity. Now, you would understand that it is very difficult as a radiation oncologist to talk about recent advances in the radiotherapy of breast cancer in 15 minutes. So what I have done is I have taken the liberty of choosing some topics and some recent advances that I think is fit for discussion here. So unfortunately, my talk is going to be a little bit more technical than the previous talk, which was a very lucid illustration on the overview of breast cancer. So please bear with me in that situation. So what we shall try to discuss today are these things: hypofractionation, post-mastectomy radiotherapy in a specific setting, which is intermediate risk, the current evidence regarding regional nodal irradiation, accelerated partial breast irradiation, radiation delivery and organ sparing approaches, as this is becoming very important, and at last, personalizing breast radiotherapy. So let's start with hypofractionation. Now, it is very well known that breast is an organ which behaves like late reacting tissue, and therefore increasing the dose per fraction is actually beneficial for the breast as compared to breast tumors as compared to other tissue. Now, there have been a number of seminal trials, largely in the UK and in Canada, and these include, of course, the trial by Timothy Whelan from Canada, as well as the START trials, of which I'll just show you in the next slide. So all of these trials have actually looked at increasing the dose per fraction and reducing the total dose. So different hypofractionation schedules have been seen. The important message that I would like to deliver here is that increasingly we are becoming aware that the alpha-beta ratio is not fixed for a particular tumor. The endpoint is actually determines the alpha-beta ratio. So now we are looking at, rather than talking about breast tumor, we are looking at an alpha-beta ratio for telangiectasia, an alpha-beta ratio for shoulder stiffness or brachial plexopathy. So that is what we will look for, and this is done from the iso effect curves that are put out here, and you can see how decreasing the total dose and increasing the dose per fraction can actually be beneficial in terms of the efficacy versus toxicity in breast cancer radiotherapy. So coming to the trials that I just alluded to, so the START pilot, followed by the START A, START B, and the Ontario trial, which is by Timothy Whelan, and this is taken from a recent review by Professor John Yarnold, which I would request all the residents to go through. It's an excellent review. So you can see the different fractionation sizes. Most of you already know about this. The important message here is that the 5-year local relapse and the 10-year local relapse was better in the hypofractionation arms, and the toxicity was not more. So essentially, this establishes hypofractionation, particularly in the whole breast radiotherapy, as a standard of care. And what do we have for that? The recommendations, the nice recommendation is that 40 gray in 15 fractions is for all curative adjuvant radiotherapy. The ASTRO has a guarded recommendation in 2011 saying that certain subsets like those above 50 years of age with early breast cancer without chemotherapy and with a dose homogeneity which is plus minus 7% in the dosimetry would benefit most from hypofractionation. However, there has been a lot of skeptics, and this has not caught on well across the world outside of Europe, although in India as well as in our institute we have changed practice for some time now. So the problems that were alluded to are basically that in certain high-risk subsets there might be an issue, and therefore I put out this forest plot where you can actually see that the high-risk subgroups, including those who are less than 50 years of age, those who have a node positivity, grade 3 or use of cytotoxic chemotherapy, they actually benefit more from hypofractionation. What is also important is to look at the cardiac dosage, which was initially thought to be an issue because heart dosage is important in breast, and it was seen that it is actually not a detriment at all. Similarly for heavy or large breasted patients. What about hypofractionation in post-mastectomy radiation? And this is perhaps the largest data, although retrospective, from Thailand, which is very recently published in 2019. And you can see the interesting part is all the patients were treated with cobalt-60, and this I think is extremely relevant for us as oncologists in India. And you can see that they had very robust evidence to show that hypofractionation was not inferior to conventional fractionation, although this is retrospective. Do we have prospective data? We do. Again, largely to 2D RT using older techniques, and that was published by Wang et al. In Lancet Oncology, and you can see you mainly using electrons, including regional irradiation. It was conclusively shown that both in terms of local recurrence as well as survival, hyperfractionation was something that was to become the standard of care. There are benefits of hyperfractionation where people are now starting to imagine to take it beyond the standard 3-week regime and to escalate the dose. So I'll just allude to some important trials which have not yet reported their results but which are important. So using intensity modulated radiotherapy with a simultaneous integrated boost approach. This is a trial from Professor Donovan. This is just the trial schema, and you can see how you are using partial breast irradiation and also escalating the dose by using different fractionation regimes. This, of course, entails that you have very precise radiation delivery techniques, and actually the import high trial has a subset built into it, which is known as the import IGRT sub-study. And here I have just given one slide to show that they are using the MR-Linac with MR image guidance on a daily basis to deliver this very high dosages of radiation. So it is extremely possible, and it is being done. The results are awaited. Can we de-escalate the dose, particularly in women who have a lesser risk of local recurrence? Can we reduce the dose or only give partial breast radiotherapy? Certainly we can. And this is again a hypothesis that is being tested in the import low study, of which the initial results in terms of toxicity were reported by Professor Charlotte Coles. And you can see that they showed that non-inferiority of partial breast and reduced dose radiotherapy compared to standard whole breast radiotherapy in terms of local relapse and late normal tissue effects. If we achieve something, we tend to become greedy. So the next step that has been taken in hyperfractionation is to go towards extreme hyperfractionation, which is essentially delivering more than 5 gray per fraction. So what is now being tried is to bring down the total dose to 30 gray and in 5 fractions or 28.5 gray. So the first of these studies was the UK FAST study, which has actually reported its mature results, and the results have clearly shown, and the primary endpoint here was not local control but cosmesis, and you can see it was shown that reducing the dose very slightly to 28.5 gray is actually beneficial in terms of looking at cosmesis. The 30 gray was slightly hard, and the cosmesis was slightly impaired in terms of breast induration and shrinkage. After that, the most interesting step taken is, of course, the UK fast forward. Here, people are now talking of delivering the entire radiotherapy within 1 week. So, dosage of 27 gray or 26 gray in 5 fractions over 1 week. So this is extreme hyperfractionation. The initial results in terms of late toxicity are already available to us, and they show that the late toxicity is actually lesser than that was anticipated in the original trial hypothesis, and this is something which is of interest for us to look as we go into the future. Just one slide in the metastatic setting, and this is again another form of hyperfractionation where we are delivering stereotactic ablative radiotherapy to bone metastasis, and this is an interesting study, particularly in triple negative patients, in luminal A patients, that has looked at delivering 20 gray single fraction dose, and they have found a progression-free survival of approximately 60% at 2 years with systemic therapy in this setting. So again, something of interest that we can look for. Coming to the next topic, which is post-mastectomy radiotherapy in the intermediate risk. So there are patients who are of high risk, and traditionally patients who are T4 or who have more than 4 positive nodes who are clear-cut candidates for post-mastectomy radiotherapy. What about patients who have 1 to 3 positive nodes? And we already have data from a very large meta-analysis by the EBCTCG group, which was published in Lancet Oncology in 2014, which showed us that both in terms of local control as well as survival, there was a benefit even in the 1 to 3 node positive subgroup of patients with local radiotherapy. I'll skip this slide because this was already talked about by my previous speaker. So the index or the CPMRT index is a practical tool which we can use in particularly these gray areas to decide whether the patient would be a candidate for post-mastectomy radiotherapy. The specific trial that is looking at the 1, 2, 3 node positive for PMRT is the Supremo trial. It is not yet reported because the accrual of this trial was not that great, and considering the fact that this was using conventional whole post-mastectomy radiotherapy, this was also a problem in the UK because already the evidence of hyperfractionation was there. But nevertheless, this trial is also going to clear some doubt regarding the role of PMRT in the intermediate risk. Coming to the next topic, which is regional nodal irradiation, and we'll start with two seminal trials that are not exactly part of the radiotherapy armamentarium, but nevertheless being discussed over the last few years. The first being the ACOSOG Z0011 trial, which my surgical oncology colleagues are very well aware of. So this has fairly established a role of sentinel lymph node biopsy alone in up to 2 node positive, sentinel lymph node positive. And the success of this trial has been attributed in many fora because of the use of radiation thereafter, particularly the high tangents, which have irradiated part of the axilla, which is not standard in everything. The update of this trial was also presented recently in 2017, and it has been found clearly that using axillary radiation without axillary dissection is actually beneficial in terms of almost all the morbidity endpoints. The second important trial here is the ambarish trial, which actually randomized patients who were sentinel lymph node biopsy positive to receive further axillary lymph node dissection or axillary radiotherapy. And again, although it was found at the 10-year update, which was presented last ASCO, that there was numerically slight increase in recurrence in the RT arm. This was not statistically significant, and in terms of morbidity, significantly axillary morbidity, RT scored better. So these are important landmark trials, and there are a few trials that are also ongoing. And if you look at the Taylor RT trial, this is interesting because it is actually looking at oncotype DX to determine whether you are going to give further treatment to the patient or not. Coming to the more contagious part of the regional nodal irradiation, which is irradiation of the supraclavicular area and the internal mammary nodes, and the indications were shown to you in the previous slide. Two very important trials were published both in the same issue of the New England Journal of Medicine in 2015. The first again by Professor Timothy Whelan and the second by Philip Putmans. And these trials, the NCIC MA20 and the URTC 22922, actually were important trials which showed that there was benefit in terms of irradiating the medial supraclavicular and internal mammary lymph nodes versus not irradiating them. In the URTC trial, the survival was almost borderline statistically significant, and there has been a lot of debate regarding the methodology of these trials, especially also because IMN only trials are very few, and these are only 2 of those trials, one from the French group with a robust follow-up, and the other from the Danish group, both of which have seemed to show that there is a 3 to 4% benefit from IMN irradiation. Bear in mind, the Danish group actually did not include left-sided patients. So there remains an issue regarding cardiac morbidity. I'll take 5 minutes more, I'm sorry, because I have a lot of data to go through. So 3 to 4% benefit actually they showed in terms of survival, but with some amount of cardiac morbidity. However, the most robust evidence regarding the nodal irradiation has come from this Budak meta-analysis, which showed clearly that there seems to be benefit in terms of both local control and survival with regional nodal irradiation, combining all the recent trials. This is unpublished data which was presented at the San Antonio meeting in 2018, again from this EBCTCG group. Very large number of patients, almost 13,000, and they stratified the trials in terms of older trials versus newer trials because of the radiation technique, and they showed that consistently there was benefit in terms of recurrence and breast cancer mortality in the using regional nodal irradiation. Interestingly, non-breast cancer mortality was worse with radiotherapy in the older trials, possibly because of the morbidities to the normal tissue that happened with the RT techniques. But this was absent in the newer trials, and this benefit was maintained with the node positive PN1 or PN2 subgroup of patients. Coming quickly to APBI, and these are the various techniques of APBI that are there, and there are criteria both from the ASTRO and the JEC-ESTRO, which have looked at who are the suitable candidates and who are not the suitable candidates for doing APBI. The only trial that I'm going to highlight here is the NACBP B39, because this actually looked at whole breast versus accelerated partial breast radiotherapy. Although the mature results of this trial are not presented, the initial results have been a little bit of a disappointment for the radiation oncology fraternity, because it has shown that the non-inferiority margin was not met, meaning therefore that partial breast irradiation or APBI was actually not non-inferior to whole breast irradiation. However, we have to look into the fine prints of this trial as we go along. Coming to the RT delivery and organ sparing approaches, it is very important to know that cardiac sparing is important for breast delivery, and we have data from the Sarah Darby trial which has clearly shown that there is increasing cardiac morbidity as we go along to increase the dosage, and we have very robust contouring methodologies for contouring the cardiac substructures now, particularly the coronary arteries, and looking at dosage to them. There are techniques like the deep inspiratory breath hold, where the patient is asked to take a deep inspiration and the dosage of radiation is delivered at that point of time. This significantly reduces the cardiac dosage, as you can see in the color washes that are presented here, and also in terms of the dose volume histograms, reduction of the cardiac as well as the left lung doses, particularly for left breast irradiation. So this is becoming a standard in many centers, even in Kolkata. So a meta-analysis has actually looked at this, and about 10,000 patients, they have found that reducing the dose to the heart, the coronary arteries and the left lung is there. However, the new kid on the block regarding this is proton beam therapy, and the basic difference that from proton beam therapy is that it is delivered directly to the patient rather than in a tangential fashion where normal radiation is delivered. So you can practically spare the heart and the lung and have very good dosages without inhomogeneity still. The last part, just 2 slides that I'll talk about, is personalizing breast radiotherapy. And the first is regarding intrinsic molecular subtypes and radiation. So this is again a fascinating study which has looked at the different pathways activated by radiation which differ by the intrinsic molecular subtypes, and it has clearly been shown from the mature data that local recurrence is much higher for TNBC and HER2 subsites than the luminal A and the luminal B subsites. Not that we didn't know of this, but this is important and the evidence is now in front of us. And the last important thing that I'll talk about is the intrinsic radiosensitivity. So now people are talking that of one dose does not fit all, and actually you can look at the tumor, you can look at what is the radiosensitivity of the tumor, and accordingly you can deliver the dose. You can see here in the left graph that there is something called the guard score, and if it is more, that is the tumor is radio resistant, then you will actually have a detrimental effect until and unless you escalate the dose. So we have now moved from an era of 2D radiotherapy to the standard tangential irradiation which irradiated the heart into more conformal techniques, and now in the last picture that you see is with protons where bilateral breast irradiation is being given, sparing the normal tissues. So this has been the progress of radiation over the last 50 years or so. I'm sorry that I took a little bit more time. I think you'll bear with me.